Imagine this. A patient arrives at hospital, not with one terrible injury, but several, all hitting front parts of the body all at the same time. It's not just complicated. Our source material today calls it, quite starkly, more difficult to treat than the sum of the isolated injuries. Just think about those immediate life or death stakes. The sheer intricacy involved in trying to, well, put someone back together when their whole system is in crisis. Welcome to the deep dive. This is where we take the sources you provide and really unpack them, looking for the crucial insights, the surprising facts, the things you can actually use. Today, we're diving into the complex world of polytrauma management. We'll be looking specifically through the lens of orthopedic care, which is a critical piece of this puzzle. It's a hugely significant area in critical care, demanding precision, speed, and, well, incredible coordination. And to guide us through this, based on the excellent material you sent us, I'm joined by an expert who truly understands the nuances of managing these severe multi-system injuries. It's really good to have you here. It's a pleasure. Yes, exploring these strategies, the protocols, the challenges involved in polytrauma, especially that orthopedic component. It's absolutely vital work. It's an area where understanding that systemic impact and coordinating complex care really does define the outcomes for patients.
Absolutely. So our mission for this deep dive is pretty clear. We want to pull out the key insights, the established protocols from these sources about orthopedic care and polytrauma. We need to understand the big challenges and maybe even peek at where the field is heading. And remember, this is all based on the source material you provided. We're aiming to help you get thoroughly informed on this complex topic, and quickly. Right, let's jump in. A quick rapid-fire round to get us started. First off, the absolute basics. What is polytrauma? And why is that multidisciplinary approach not just nice to have, but critical right from the start? Okay, so fundamentally, polytrauma means multiple traumatic injuries happening at once. They affect different organ systems or body regions, and crucially, at least one of those injuries is potentially life-threatening. It's not just, say, two broken bones. It's more like having a serious head injury and a major leg fracture, and maybe chest or abdominal trauma too, all at the same time.
Ah, okay, so it's the combination hitting different systems.
Exactly. And that's why the multidisciplinary approach is so critical, right from the word go. Because you have all these different systems involved. No single medical specialty arm, no one doctor has all the expertise needed, or even just the capacity, really, to manage all those potential life threats and injuries simultaneously.
Yeah.
You need that immediate coordinated action. Emergency medicine, general surgery, orthopedics, neurosurgery, anesthetics, critical care. The list goes on. Their integrated effort is essential to figure out the full scope of the damage and stabilize the patient effectively.
Right, so it's the interaction between those different injuries that really ramps up the complexity, not just adding them up. Okay, next one. The ABCDE approach. Can you briefly explain what that is and its absolutely core role in those first critical moments?
Yes, the ABCDE approach is really the bedrock of the primary survey in ATLS, that's Advanced Trauma Life Support Protocols. It's a mnemonic. A is for airway, with cervical spine protection. B is breathing and ventilation. C, circulation with hemorrhage control. D, disability or neurological status. And E is exposure, with environmental control, meaning keeping the patient warm. Its fundamental role. It provides a stripped, systematic way to find and manage immediate life-threatening problems, and importantly, in a specific prioritized order.
So first things first.
Absolutely. You manage the airway first, because if the patient can't get oxygen in, nothing else matters, does it? Their breathing, then circulation, and so on. It imposes that essential order and priority onto what is often a chaotic, incredibly time-sensitive situation. It ensures the most critical threats get dealt with immediately.
Makes perfect sense. Tackle the biggest dangers sequentially. And the last rapid-fire question before we dive deeper. Orthopedic injuries. What unique challenges do they bring to this already very complicated picture, beyond just being another injury on the list?
That's a key point. Orthopedic injuries, especially the major ones like pelvic fractures or fractures of big, long bones like the femur,
Yeah.
they introduce several really critical challenges in polytrauma. Firstly, they can cause significant bleeding, sometimes massive blood loss, actually. This directly worsens any circulatory instability or shock the patient might already have from other injuries.
Right, the hidden bleeding.
Exactly. Secondly, they're incredibly painful. This pain contributes significantly to the whole body inflammatory response that trauma kicks off. Thirdly, fixing them surgically definitive fixation can itself be quite demanding physiologically. These operations can be long, involve more blood loss, and potentially worsen the patient's condition if the timing isn't right.
Ah, the timing issue. We'll come back to that.
Yes. And finally, these injuries have a huge impact on long-term mobility, function, quality of life. So how you manage them has to be part of the patient's overall recovery plan right from day one.
Fascinating. Okay, that sets the scene brilliantly. Let's really unpack this now, starting with those foundations. You've mentioned polytrauma involves multiple organ systems, and the sources call it a significant public health concern. Can you expand on that specific phrasing? Why public health? What are the broader implications here?
Well, it's called a significant public health concern because its impact really does go far beyond the individual patient or the immediate medical challenge. Polytrauma is a major cause of death and long-term disability, especially in younger people. Often it's the result of high-energy events, road accidents, falls from height, industrial incidents. The numbers globally are substantial.
Yeah.
And the sheer complexity of managing these cases means they consume vast healthcare resources. You're talking prolonged hospital stays, multiple surgeries, intensive rehabilitation, specialized staff, expensive equipment.
A huge drain on the system.
A huge drain. And then there's the high rate of long-term problems. Permanent disability, chronic pain, psychological issues like PTSD. This creates a significant societal burden. Lost productivity, ongoing care costs, the impact on families. So you see, it's not just one person's medical problem, it's a major factor in overall population health and carries a significant economic weight.
That really puts the scale of it into perspective, and dealing with this public health challenge, as you said, demands that big multidisciplinary team. How do they actually achieve that synchronicity, especially when a severely injured patient first comes in amidst all the chaos? You mentioned ATLS protocols earlier.
Yes, ATLS is absolutely fundamental for achieving that synchronicity. It provides a standardized, repeatable framework that every member of the trauma team knows and follows, regardless of their own specialty. It dictates the sequence of assessment, the initial interventions. It makes sure everyone is quite literally on the same page, focusing on the same priorities in the same order. The goal, as the source material points out, is exactly that, to improve patient outcomes and recovery by having structured communication and coordination.
Like a shared playbook for those first critical moments.
Precisely. It acts as the team's playbook for that first most critical phase. It helps minimize errors, cuts down delays, and ensures that nothing immediately life-threatening gets missed in the heat of the moment.
Could you walk us through that initial assessment phase? It actually starts before the hospital, doesn't it?
It does, yes. The initial assessment begins right at the scene with the pre-hospital providers, paramedics, emergency medical technicians. They're working under challenging conditions, often. Their job is a rapid but thorough assessment focused on finding and managing the most immediate threats before they even start transport. They'll check a patient's overall status consciousness, breathing effectiveness, signs of circulation. A really critical part is the airway check. Are there any signs of blockage, blood, vomit, foreign objects, or risk factors like facial trauma or reduced consciousness? Can the patient keep their airway clear?
So basic life support, essentially, but under pressure.
Yes, and potentially advanced assessments too. Looking for anatomical issues, deciding if an airway adjunct is needed or working. The focus pre-hospital is rapid stabilization, stopping any obvious major bleeding, and ensuring safe, fast transport to the right kind of hospital or trauma center.
And then they arrive at the trauma center, and that systematic approach really ramps up with the primary survey, the ABCDE we talked about. Can you break down each step again and why the sequence is so vital?
Certainly. The primary survey happens immediately in the resuscitation bay. A is airway with cervical spine protection. This is always first. Is the airway open, secure? Is the patient talking? Any sounds of obstruction? Is the neck stabilized? If the airway is compromised, it must be secured, maybe with intubation before you do anything else. And keeping the spine safe is crucial because of the potential for spinal injury.
Okay, airway first. Then B.
B is breathing and ventilation. Airway secure. Right now is the patient breathing effectively. Chest moving symmetrically. Breath sounds present on both sides. Any signs of serious chest injuries like a tension pneumothorax, a collapsed lung under pressure, or a massive hemothorax, which is a chest full of blood, these need immediate action like inserting a chest drain.
Got it. Airway, breathing, then C.
C is circulation, with hemorrhage control. After A and B are sorted, the next immediate threat is bleeding. You check circulation, heart rate, blood pressure, skin color, how quickly color returns when you press the skin. At the same time, you actively look for and control any external bleeding. Direct pressure, maybe tourniquets. You get IV lines in quickly to give fluids or blood products if they're in shock from blood loss. Internal bleeding is trickier to spot immediately, but signs of shock point towards it.
Makes sense. Stop the bleeding, support the circulation. What's D?
D is disability. This is a quick check of neurological status.
Yeah.
It's the patient's level of consciousness. often using the Glasgow Coma Scale or GCS. Are their pupils equal, reactive to light? Can they move their arms and legs? This step flags up major neurological problems, potential head injuries.
And finally, E.
E is exposure with environmental control. You need to fully undress the patient, expose them to do a thorough visual check for any injuries you might have missed. But, critically, you immediately cover them back up and use warming blankets or devices. Preventing hypothermia getting cold is vital, as being cold makes bleeding problems, coagulopathy, much worse.
That step-by-step logic is very clear. Primary survey is all about stopping immediate death, stopping bleeding, ensuring oxygen gets in, maintaining basic function right now. What comes after that initial crisis management?
Right, so once the primary survey is done, the immediate life threats are being addressed, and the patient is, let's say, relatively stable physiologically, only then do you move on to the secondary survey. This is a much more detailed assessment, a comprehensive head-to-toe physical exam looking for every single injury, not just the ones that could kill them in the next few minutes. You try to get a detailed history mechanism of injury, allergies, meds, past history, last meal, the AMPLE history, we call it. And this is also when you start doing more diagnostic tests to build the complete picture.
So the secondary survey is about finding all the damage, big or small, that wasn't an immediate life threat.
Exactly that. It's about uncovering the full extent of the trauma. Finding injuries that aren't immediately fatal, but are still significant orthopedic injuries, maybe milder head injuries, soft tissue damage, internal injuries that weren't obvious initially. The information from the secondary survey, combined with the results from diagnostic tests, lets the trauma team establish a definitive diagnosis of all the injuries. And from there, they can create a comprehensive treatment plan, often involving multiple specialties, that goes beyond just the initial resuscitation. It shifts the focus from pure survival to complete injury identification and planning for definitive care and long-term recovery.
That's a really crucial distinction. And what are the key diagnostic tools used during this more comprehensive assessment? The sources mentioned EFAST and X-rays specifically.
Yes, those are absolutely core tools, often used very early, sometimes even during the primary survey, if needed and feasible. EFAST stands for Extended Focus Assessment with Sonography and Trauma. It's basically a portable ultrasound scan done right there in the resuscitation room. It's incredibly valuable for quickly detecting free fluid, usually blood in specific body cavities, around the heart, in the spaces around the lungs, and in the abdomen. It gives you a rapid indication of internal bleeding without having to move the patient to a CT scanner immediately. It's fast, non-invasive, repeatable, really ideal for unstable trauma patients.
And the X-rays, chest and pelvis.
Chest and pelvic X-rays are also standard, critical initial investigations. Following ATLS principles means interpreting them systematically. The chest X-ray can show things like a collapsed lung, pneumothorax, blood in the chest cavity, hemothorax, bruised lungs, pulmonary contusions, or broken ribs. The pelvic X-ray is vital because pelvic fractures can cause absolutely massive, life-threatening internal bleeding and instability. You're not just glancing at these films, you're systematically checking things like image quality, alignment of bones, looking for foreign bodies, and specific fracture patterns in key areas, just as the ATLS guidelines teach. They provide essential, rapid information about major structural damage.
Okay, so you've done the systematic assessment, used tools like EFAST and X-rays. How do you then quantify the overall severity? Taking all these different injuries together, is that where scoring systems come in?
Precisely. With polytrauma, you need a way to communicate just how badly injured the patient is overall. Scoring systems help do that objectively. They quantify the severity, standardize assessment so you can compare patients or centers, and, importantly, they help predict outcomes and guide treatment decisions. They give you a number that represents the total trauma burden.
And the sources mention two key ones, the Injury Severity Score, ISS, and the Abbreviated Injury Scale, AS. How do they work? Are they related?
Yes, they're directly related. The Abbreviated Injury Scale, AIS, is the building block. It's an anatomically based scale that ranks the severity of a single injury within a specific body region. It uses a 6-point scale. 1 is minor, 2 moderate, 3 serious, 4 severe, 5 critical, and 6 is maximal, essentially unsurvivable. There are detailed AIS dictionaries for injuries in different body regions: head, face, chest, abdomen, limbs, external injuries.
So AIS scores individual injuries. How does that become the ISS?
Right. The Injury Severity Score, or ISS, is calculated from those AIS scores. What you do is first you determine the AI score for the worst injury in each of 6 defined body regions. Then you take the highest AI scores from the 3 most severely injured body regions. You square each of those 3 scores, and then you add those squared numbers together. So ISS equals top AI score 1 squared plus top AI score 2 squared plus top AS score 3 squared. The maximum score is 75. Any single injury scores an AS of 6. The ISS automatically becomes 75. Generally, an ISS score over 15 is considered major trauma.
And why is that ISS score so important?
Its key significance, as the sources highlight, is that it correlates pretty well, often linearly, with patient outcomes. Things like mortality risk, likelihood of complications, length of hospital stay, level of disability. A higher ISS score is a strong indicator of the tougher road ahead for the patient.
So these scores essentially provide a numerical snapshot of the total physiological hit the body has taken across different areas.
That's a good way to put it. They offer an objective measure that helps the whole team grasp the overall load on the patient. It helps anticipate how much support they'll need, predict potential problems, estimate recovery time, and it allows for standardized comparisons vital for research, for quality improvement, for comparing how different trauma centers are doing.
This leads us perfectly into focusing more specifically on the orthopedic injuries themselves. As you said earlier, they're a major part of the picture in many polytrauma cases. You described orthopedic injuries as major components whose management plays a crucial role. Could you expand on that? What types of orthopedic injuries are most common or perhaps most worrying in this context?
Yes, orthopedic injuries, mainly fractures and dislocations, are incredibly common in the kind of high-energy events that cause polytrauma. Think about the forces involved in major car crashes or falls from a height. These often lead to fractures of the pelvis, the femur, thigh bone, the tibia, shin bone, the spine, and the upper limbs. Their management is crucial, not just for the limb itself, but because they massively influence the patient's overall systemic condition. A closed femur fracture, for instance, can easily bleed 1 or 2 liters of blood into the thigh tissues that significantly worsens shock. Pelvic fractures can bleed even more, catastrophically sometimes.
Wow, that much from just a broken leg.
Absolutely. And beyond the bleeding, these injuries cause intense pain, needing lots of pain relief, and they add significantly to that systemic inflammatory response we talked about. Certain orthopedic injuries, as the sources point out, carry specific immediate dangers. Knee dislocations are a classic, really serious example. This isn't just the kneecap popping out, it's the main shin bone, the tibia, becoming completely displaced from the thigh bone, the femur. The forces required are huge, meaning there's a very high risk of damaging the main artery behind the knee, the popliteal artery.
And that's critical.
Extremely critical. If blood flow through that artery is cut off for even a few hours, the chances of losing the leg below the knee become very high indeed. There's also a big risk to the nerves around the knee, which can lead to permanent foot drop or other problems. So a suspected knee dislocation needs immediate action, reducing it to take pressure off the artery, then urgently assessing the blood flow, often with scans even if you can initially feel a pulse.
That really highlights the critical link in orthopedic injury creating an immediate vascular emergency. Now, given this complexity and the fact the patient might be very unstable, there's a big debate about when to surgically fix these fractures, isn't there? The sources mention early total care versus damage control orthopedics.
Yes, this is absolutely a central discussion, sometimes quite a heated one, in polytrauma orthopedics. Let's break them down. Early total care, or ETC, basically means doing the definitive surgical fixation, putting in plates, rods, screws internally relatively early. Often within the first 24 hours or so if the patient is physiologically stable enough to tolerate it. The thinking behind ETC is that fixing fractures properly early on reduces pain, lets the patient mobilize sooner, cuts down on complications of being stuck in bed like chest infections or blood clots, and should lead to faster recovery overall.
Okay, so fix it early if you can. What's the alternative? Damage control.
Damage control orthopedics, or DCO, is quite different. It's a staged approach, used mainly for those physiologically unstable polytrauma patients. Instead of going straight for the big, definitive internal fixation, the first orthopedic operation is much more limited. It focuses on rapid, temporary stabilization. Most often, this means using external fixators, metal frames outside the limb, holding the bones roughly in place with pins that go through the skin into the bone. This procedure is much quicker, less invasive, and puts far less physiological stress on the patient than a major internal fixation operation.
So you put a temporary frame on first.
Exactly. The patient is then managed in intensive care, their overall condition is optimized, resuscitation continues, inflammation settles, clotting improves, and then the definitive internal fixation surgery is delayed, sometimes for days, maybe even a week or two, until they are much more stable and better able to cope with a major operation.
So DCO is deliberately putting off the proper fix. Why is that better for unstable patients? You mentioned avoiding the second hit earlier.
That's precisely the core idea. The philosophy of DCO is all about preventing further physiological insult, avoiding that dangerous second hit. Severe trauma itself, the first hit, triggers this massive wave of inflammation throughout the body. Now imagine adding a major orthopedic operation on top of that, especially a long, complex one on the pelvis or femur. That surgery is another significant physiological stressor the second hit. It involves more tissue damage, more potential blood loss, release of more inflammatory signals.
The surgery itself can make things worse.
In a patient who is already critically ill in shock, maybe struggling to clot their blood, already highly inflamed from the first hit, yes, this additional surgical stress can push them over the edge. It can fuel that inflammatory fire, potentially leading to devastating secondary complications like ARDS, acute respiratory distress syndrome where the lungs basically shut down, or MOF, multiple organ failure.
That makes sense. Give the body a chance to recover from the first hit before subjecting it to the second.
Precisely. DCO minimizes that initial surgical stress. It provides just enough bone stability to allow safe handling, nursing care, and transport for scans, while giving the patient's body crucial time to recover from the initial shock and inflammation before they have to face the physiological burden of the definitive reconstruction. The sources note this debate and mention the DCO favoring delay to avoid that extrasurgical trauma is quite common in managing unstable patients in some places, like hospitals in China referenced in the material. It's a strategic choice, weighing the benefits of early fixation against the patient's immediate capacity to tolerate it.
That second hit concept is really powerful. It really explains the rationale behind DCO. It's almost counterintuitive, isn't it? That doing the necessary fix too soon could actually be harmful. So where do current treatment protocols generally stand on surgical timing?
Well, current thinking and practice, as reflected in the protocols described in the source material, generally leans towards being more cautious initially, especially for those severely injured, physiologically unstable patients. This aligns more with the DCO principles. The trend is really towards prioritizing resuscitation and critical care, getting the patient's overall physiology stable before embarking on major definitive orthopedic surgery. The decision-making is very dynamic, though. It's not a fixed rule. The team continuously reassesses the patient's condition, looking at their response to resuscitation, inflammatory markers, clotting status.
So it's judged case by case.
Very much so. For patients who are stable from the outset, early total care might still be the way to go. But for those who are borderline or clearly unstable, delaying the big orthopedic operation is often seen as the safer strategy to try and prevent those potentially fatal secondary complications.
And once the surgeries are done, whether early or delayed, how is the patient's long-term recovery assessed? It sounds like a very long road.
Oh, it certainly is. The recovery journey after polytrauma, especially with major orthopedic injuries, is prolonged and complex. Long-term follow-up is absolutely crucial, and the protocols include specific benchmarks for this. It involves checking how the fractures are healing, often using X-rays at set time points, like 9 months post-surgery, as mentioned. Assessing joint mobility is critical too, using standardized scoring systems that measure a range of movement and how well the limb functions. But it goes beyond just the physical. The overall quality of life is a major outcome measure. This is usually assessed using comprehensive questionnaires or surveys that look at physical function, pain levels, psychological well-being, ability to return to work or daily activities, social integration.
A much broader view of recovery.
Exactly. This kind of multidimensional follow-up is vital. It tells us how successful the whole treatment pathway has been, helps identify any ongoing problems or complications, allows rehabilitation to be tailored, and provides the support needed for the patient to hopefully reintegrate back into their life as fully as possible.
It's clearly about much more than just mending bones. It's about restoring function and quality of life. All of this really underlines why having well-defined structured protocols is so important. Why are they considered so critical, and is there good adherence to them generally?
Protocols are crucial because the evidence strongly backs them up. Research shows that structured, protocol-driven trauma care significantly reduces critical delays. Things like the time spent in the initial resuscitation phase, what's sometimes called reanimation time, and delays in getting patients to necessary surgery. By standardizing the approach, you reduce unwanted variation in care, minimize the risk of missing crucial steps, and improve how the team coordinates. The result, as the sources indicate based on research, is demonstrably better outcomes, lower rates of complications, morbidity, and death mortality. Having a robust, well-practiced protocol for activating and managing the trauma team is simply essential for handling these severely injured patients effectively and efficiently.
But having a protocol is one thing. Are they actually used consistently?
Well, that's the challenge. Implementing them and ensuring consistent adherence remains a significant hurdle. The sources mentioned a survey finding that, worryingly, only a portion of hospitals, even those designated as trauma centers, actually have comprehensive polytrauma protocols fully embedded in practice, based on established guidelines like ATLS. This gap between what we know as best practice and what happens on the ground highlights a real need for ongoing training, quality improvement initiatives, and system changes to ensure these life-saving protocols are followed consistently across the board. Having the blueprint is vital, but consistently building according to that plan, especially under intense pressure, is the real test.
That gap in adherence is a sobering thought. It reminds us that even with the best guidelines, execution is absolutely key. And even when protocols are followed by skilled teams, managing polytrauma patients is just incredibly tough and full of potential complications, isn't it? We started by saying it's harder than the sum of its parts.
It absolutely is. The very fact of having multiple severe injuries hitting different systems creates, well, a perfect storm for complications. Complications that are often less common, or certainly less severe, if you only have an isolated injury. This stems from that complex interplay of physiological responses triggered by the initial trauma. The sources talk about the four vicious cycles. The injury itself leads to bleeding, hemorrhage. The hemorrhage contributes to problems with blood clotting, coagulopathy. The coagulopathy makes the bleeding worse, and all of this fuels massive systemic inflammation, which then further disrupts organ function and worsens the coagulopathy. These cycles can feed off each other very quickly, leading to a downward spiral unless they're aggressively interrupted.
Let's explore some of the specific complications highlighted in the sources. Infections seem to be a major concern.
Yes, infections are a really prevalent and dangerous complication in polytrauma. These patients are highly susceptible. They have severe tissue damage, often open wounds, multiple invasive lines and tubes needed for monitoring and treatment, and crucially, their immune system takes a hit because of the trauma itself. The initial trauma and the subsequent inflammatory storm can actually suppress parts of the immune response, making patients much more vulnerable to bacterial and fungal infections. Sepsis, the body's overwhelming and life-threatening response to an infection, is tragically highlighted in the sources as the second leading cause of death in polytrauma patients, right after uncontrolled bleeding.
Second only to bleeding, that's stark.
It is, and certain injuries significantly raise that infection risk. Abdominal injuries, for example, where there's potential contamination from bowel contents, or having fractures in both femurs due to the sheer scale of tissue damage and blood loss involved. Constant vigilance for any sign of infection is absolutely paramount throughout the entire hospital stay.
Spinal injuries were another area mentioned, particularly common in traffic accidents. What's the specific danger there in the polytrauma setting?
Spinal trauma is alarmingly frequent, with the kind of high-impact forces that cause polytrauma. The statistics cited are quite sobering studies suggesting up to 93% of fatalities in road traffic accidents might have cervical spine fractures, and many survivors sustain fractures in the thoracic or lumbar spine. The major risk, of course, is damage to the spinal cord itself. This can lead to permanent neurological deficits, paralysis being the most devastating. That's exactly why the A of ATLS includes cervical spine protection, keeping the spine immobilized until injury can be safely ruled out, usually with imaging.
So early recognition is key.
Critical. Adhering strictly to ATLS principles, including careful examination and specific techniques like the log roll, turning the patient carefully as a single unit to check their back while keeping the spine aligned, is vital. If a spinal cord injury is suspected, managing associated problems like spinal shock is also crucial. That's a type of shock caused by the injury interrupting nerve signals, leading to low blood pressure. It needs careful fluid management and sometimes medications to support blood pressure and maintain blood flow to the injured cord, trying to prevent further damage.
And then there are complications linked directly to the surgery itself, connecting back to that second hit idea.
Absolutely. While surgery is often essential, especially for fixing orthopedic injuries, it carries its own risks in the already fragile polytrauma patient. Musculoskeletal operations, which are very common in this group, involve significant tissue handling, potential for more blood loss, and putting foreign material like metal implants into the body. This surgical intervention can trigger an exaggerated immune and inflammatory response in a patient whose system is already on high alert from the initial trauma. This surgical hit can significantly worsen the existing systemic inflammation. This increases the risk of those severe complications like ARDS, lung failure, and MOF, multiple organ failure, that we discussed earlier. The whole strategy around timing of surgery, particularly using DCO for unstable patients, is specifically aimed at mitigating this very risk, letting the patient cool down physiologically before undergoing major operations.
And finally, coagulopathy, those blood clotting problems, was flagged as a major challenge. How does that typically manifest after trauma, and how is it tackled?
Trauma-induced coagulopathy is a really complex and often deadly problem. Severe trauma, especially when there's major bleeding, doesn't just mean losing blood volume. It frequently messes up the body's ability to form clots effectively at the same time. It's caused by a combination of things. Clotting factors get diluted by the fluids we give during resuscitation. They get used up trying to stop the bleeding. Platelets get consumed. The cold temperature, hypothermia, and acidosis, buildup of acid in the blood, that often occur after severe injury, impairs the enzymes needed for clotting. And sometimes the body even starts breaking down clots too quickly, fibrinolysis.
A perfect storm for continued bleeding.
Yep. Exactly. Managing it is incredibly difficult, a real balancing act. The standard approach is transfusing blood components, red cells for oxygen, plasma for clotting factors, platelets. But getting that balance right quickly in someone who is actively bleeding and coagulopathic is tough. The sources mention research into other agents like recombinant factor VI, or FVIL, which is a potent clotting factor. One study found that while it did seem to reduce the amount of blood transfusion needed, it didn't actually show a significant improvement in survival rates. This suggests that trauma-induced coagulopathy isn't just a simple lack of clotting factors. It's a much more complex systemic problem. Finding better, safer ways to manage it effectively remains a really active area of research.
It's undeniably a field facing immense interconnected challenges. It demands constant vigilance, deep understanding, and incredibly skilled, coordinated management. So we've covered the complexity, the challenges, the significant risks, which brings us right back to something you mentioned early on, the absolute need for effective teamwork and training to navigate all this. Our source material included some interesting case study insights on this very topic. What did they reveal about how teamwork actually impacts polytrauma care?
Yes, the case studies really hammered home the profound impact that good teamwork and communication have on patient outcomes, especially in these high-stakes trauma situations. The research showed that applying principles from crew resource management, CRM, which, as you may know, originally came from aviation, to improve safety by focusing on teamwork, communication, decision-making under pressure, significantly boost these skills within trauma teams. This includes things like using clear, closed-loop communication, confirming you've heard and understood instructions, offering mutual support, maintaining awareness of the overall situation, and having clear leadership.
So skills borrowed from the flight deck applied to the emergency room.
Essentially, yes. And one particularly striking finding was about the impact of specific training programs. Studies described interventions that combine traditional classroom teaching on things like patient safety, communication strategies with high-fidelity simulation exercises. That simulation part is key. It lets teams practice coordinating care, communicating effectively under pressure, applying the protocols in a realistic setting, but without any risk to a real patient. One study reported finding sustained improvements in how well the teams performed things they could measure for up to 24 months after the team members had done this combined training.
A few years later, that's really impressive.
It is impressive. It suggests that investing in this kind of structured, simulation-based teamwork training isn't just a short-term fix. It can actually embed those crucial behaviors and coordination skills for the long haul, directly making the team better at managing complex trauma resuscitations effectively.
That 24-month finding is incredibly encouraging. It suggests a real, lasting benefit from that kind of training investment. And how does that better teamwork then translate into actual, tangible improvements for the patients themselves?
Well, the research gives some concrete examples. Although not specific just to orthopedic trauma, one randomized trial looked at multidisciplinary teams providing medication education to patients before discharge. They found a 20% reduction in hospital readmissions within 60 days compared to the standard approach.
But a 20% drop is significant.
It really is. And it illustrates a principle that's highly relevant to polytrauma. When all the different specialists, surgeons, nurses, pharmacists, physio, social workers function as a truly cohesive unit, communicate effectively, share information properly, coordinate their plans, it leads to better patient outcomes, fewer complications, better recovery, less chance of bouncing back into hospital. The synergy of that team provides a level of care that individuals working in silos just can't match.
Can you give us a quick picture of what that multidisciplinary teamwork looks like in action, right there in the heat of the moment, during the initial resuscitation?
Okay, so picture the scene in the emergency department's resuscitation bay. A severely injured patient arrives. Immediately, you see this rapid expansion of the core trauma team. Based on the information from paramedics about how the injury happened and the initial assessment findings, specific specialists are called in very quickly. Maybe an orthopedic surgeon for suspected fractures, a neurosurgeon if there's concern about a head injury, a general or abdominal surgeon, an anesthetist managing the airway and circulation, critical care nurses. They all converge and integrate into the resuscitation effort. Each brings their own expertise, but crucially, they operate under a designated trauma team leader, following that structured ATLS protocol.
And it extends beyond the purely medical, too.
Absolutely. The source material rightly emphasizes that comprehensive polytrauma care goes beyond just the doctors and nurses fixing the physical injuries. The role of support services is vital. Social workers are crucial for helping families cope with the crisis, understand what's happening, and start thinking about long-term care needs or rehabilitation. Pastoral care provides that essential emotional and psychological support, not just for the patient, but for their distraught family members too. It really has to be a holistic effort, addressing the whole person and their support network during an incredibly traumatic time.
Okay, let's try and boil this down. Based on everything in the sources, what are the absolute core pillars, the quick wins, the must-know concepts for anyone working in or near this field?
Right, the absolute must-knows based on these sources. I'd say, firstly, you have to master that systematic assessment framework from ATLS. It's the essential scaffolding for that critical initial phase. Secondly, really understand the fundamental difference between early total care and damage control orthopedics. And critically, grasp why you'd choose DCO for unstable patients, that whole second hit avoidance rationale.
Okay, ATLS, ETC versus DCO. What else?
Thirdly, be acutely aware of and constantly vigilant for those key complications we discussed: sepsis, coagulopathy, potential spinal injuries, and that overwhelming inflammatory response. Understand why polytrauma patients are so uniquely vulnerable to these. Fourthly, know how to use and interpret the injury scoring systems like ISS and AIs. They're the tools for quantifying the overall severity and helping predict the patient's likely path.
Right, the scores. And lastly,
And finally, recognize the immense value of teamwork and communication. Actively work to improve those skills, perhaps through CRM-style training, understanding that the evidence shows it genuinely improves team performance and patient outcomes.
perfect. So, the initial plan, ATLS, the big surgical strategy decision, ETC-TCO, the major dangers to watch for complications, how you measure the damage scores, and the crucial human factor, teamwork. That really covers the critical ground. Before we wrap this up, thinking back through our discussion, were there any specific parts that felt particularly powerful or concise, maybe suitable for a short, impactful clip that captures a core idea from this deep dive?
Yes, I think two areas really stand out for highlighting key insights. Firstly, that fundamental definition of polytrauma, particularly emphasizing the point that it is more difficult to treat than the sum of the isolated injuries. That concept immediately conveys the complexity and justifies why a specialized approach is needed. It's a very memorable idea.
Okay, the more than the sum of its parts concept. What's the second one?
The second would be the explanation of the second hit phenomenon, specifically linked to surgical timing and the rationale for damage control orthopedics. Well, the idea that doing necessary surgery too early can actually harm a fragile patient, and the strategic thinking behind delaying it to mitigate that risk, that's a really crucial, perhaps counterintuitive insight into the challenges of managing these patients orthopedically. It's nuanced, but absolutely vital.
Excellent choices. Those definitely capture two of the most thought-provoking and impactful themes we've explored today. Right, so let's bring it all together for everyone listening. Time for the key actionable takeaways from this entire deep dive. Based on the comprehensive source material we've navigated, what are the absolute core points you should really take away?
Okay, takeaway number one. Managing polytrauma is fundamentally a team sport. It absolutely demands that truly integrated multidisciplinary approach. Seamless communication, tight coordination right from the moment of injury all the way through to long-term recovery. It's not just good practice. It's essential for survival and getting the best possible outcome.
Couldn't agree more. Teamwork is paramount. What's number two?
Second, mastering systematic assessment protocols, especially ATLS, is non-negotiable. These frameworks, backed up by diagnostic tools like EFAST and careful X-ray interpretation, are really the only reliable way to quickly find and prioritize the multiple, complex, life-threatening injuries that these patients present with. Structure is safety here.
Okay, structured assessment is key. Third takeaway.
Third, specifically in orthopedic polytrauma, That decision between early total care and damage control orthopedics is a critical strategic choice. It has to be driven by the patient's overall physiological stability. Recognizing when a patient is just too unstable for immediate definitive surgery to avoid that dangerous second hit is absolutely paramount. Timing is everything.
Right, strategic surgical timing based on stability. Fourth,
Fourth, maintain continuous vigilance. Keep a high index of suspicion for those specific complications, especially sepsis, coagulopathy, missed spinal injuries, and that runaway inflammatory cascade that can lead to lung failure, ARDS, and multiple organ failure, MOF. These aren't just abstract risks, they are significant, ever-present threats in the polytrauma setting. You have to actively look for them throughout the patient's entire journey.
constant vigilance for the big dangers. And the final takeaway.
And finally, the evidence is compelling. Investing in and properly implementing structured teamwork training, using principles like CRM, and ensuring robust adherence to established protocols demonstrably improves how teams perform. And crucially, this leads to tangible benefits for patients, reducing delays, cutting complications, and ultimately saving lives. Training and protocols matter.
Those are incredibly clear and powerful takeaways. They really do crystallize the essential messages from our sources today. Looking toward the future now, the source material did touch upon where this complex field might be heading. What does the horizon look like for orthopedic polytrauma care?
Well, the field is definitely not standing still. It's constantly evolving, pushing for greater precision, better integration between specialties, and an enhanced focus on the patient. The future directions mentioned in the sources include, perhaps unsurprisingly, an increasing role for technology. Things like robotic-assisted surgery are mentioned, holding promise for maybe greater accuracy in complex orthopedic procedures, although obviously cost and widespread availability are still factors to consider. Enhanced interdisciplinary collaboration is also a huge focus, perhaps using structured communication frameworks like TeamStep even more broadly to boost team performance and safety culture.
So better tech and better teamwork structure.
Yes, alongside a strong push for more robust research, generating even stronger evidence for best practices, perhaps using things like comprehensive scoping reviews to really synthesize all the existing knowledge effectively. Technological innovations will continue too. You hear about advanced 3D imaging for incredibly detailed preoperative planning, even ideas around smart implants that might one day monitor fracture healing or detect early signs of infection.
Fascinating possibilities.
And importantly, alongside all this high-tech development, there's a growing emphasis on truly patient-centered care, ensuring that even within this incredibly complex, high-pressure, protocol-driven environment, the individual patient's needs, their preferences, their long-term functional goals, that these remain absolutely central to every decision made. It's about integrating that human element even more deeply into the whole system.
It's really interesting to see that expected evolution technology and collaboration advancing hand in hand with a stronger focus on the individual patient's journey within such a demanding area of medicine. And these core principles we've discussed how to manage incredibly complex systems under immense pressure, the critical importance of high-performing teams, integrating new technology effectively while staying laser-focused on the core mission, and always prioritizing the individual within a highly protocolized system, these surely resonate far beyond just the medical field, don't they? If you found these insights valuable today, please do consider sharing this deep dive with your colleagues or network, or perhaps leaving us a rating wherever you listen. It really helps others find the show. Which leaves us with a final thought to ponder. As technology continues its rapid advance in critical care and complex protocols become even more sophisticated, how do we truly ensure that the human element, that individual patient's unique journey towards recovery, their specific needs and values, remains the absolute undeniable centerpiece around which we design these entire systems of care? Thank you so much for guiding us through this incredibly complex and vital area today, based on the material our listener provided. It's been truly insightful. And thank you, our listener, for providing the sources that made this deep dive possible. We hope it's given you a much clearer, more detailed understanding of the intricate world of orthopedic polytrauma management.